Yes, madam. Yes, clear.
Okay, great. So just before starting, guys, I'd like to clarify something, which is the same happened last year. Guys, the GMT timing or the GMT time zone, it's a changing every March and October. So that's why you may get confused with the time. So please, when just I'm going to post any kind any date or any time, please check that at Google whether it's at the time difference with KSA 3 hours or 2 hours, the time difference with too many countries. Please check that because the time changing, the summertime and winter time every March and October, and the same happened with me last year. So it seems that some of you get confused, guys. So let's start our first case. I have been asked from Dr. Kumal. Dr. Kumal, are you here?
Yes, Dr. Allah. Assalamu alaikum.
Wa alaikum salam. So, Dr. Kumal, this is your case, and it seems that you've done too many station fours with me. So, this is your case, and you will have 4 minutes to prepare your thoughts and go.
Okay.
Okay, time up. Are you ready?
Yes, doctor.
Okay.
Can you hear me?
Yeah, I can hear you.
Hello, my name is Dr. Zahid. I'm one of the doctors in the tummy clinic. Are you Mr. David Webster, husband of Mrs. Sally Webster, 55 years of age?
Yes, doctor, I am.
Okay, Mr. Webster, we're here to discuss about your wife's health condition. Is that fine?
Yeah, sure, doctor.
Okay, so may I know how much do you know about her health condition?
Well, doctor, Sally, she has been recently diagnosed with a disease called motor neuron disease. And after that, her health started to decline, doctor. So she got multiple chest infection. And I think this time she got chest infection as well. And I'm not sure whether it's something related to her disease or not. And I'm just wondering, doctor, how's she now?
Okay, well, Mr. Webster, first of all, I'm very sorry that your wife and you are going through a difficult time. And let me assure you, we're here to help you.
Thank you, doctor.
So, your Mrs. Webster is fine at the moment, but I want to discuss with you why she is having some recurrent infections of her chest. Regarding that, do you have anything running through your mind what it could be?
Well, doctor, just during my research regarding her motor neuron disease, I've noted that all the muscles could be weak. So I'm just wondering whether the respiratory muscle as well, it's it's weak now. That's why she got this recurrent chest infection.
Okay, Mr. Webster. Well, I appreciate your knowledge and your research, and I'm afraid that you are correct, and I'm afraid to tell you that this is also a complication of her motor neuron disease.
So, doctor, the respiratory muscle now it's weak.
Yes, Mr. Webster, I'm so sorry to tell you that it seems that this could have been one of the reasons for her recurrent chest infections.
How, doctor? Would you please explain more?
Yes, Mr. Webster, would you like me to tell you more about motor neuron disease, what it is?
No, doctor, I've got enough information regarding this. Just I'd like to know more regarding her chest infection and why she got recurrence.
Okay. Well, right now we have assessed her and we have examined her, and we are suspecting she is suffering from a condition called as aspiration pneumonia. And have you heard about this?
No, doctor, ever. What is it?
You are somewhat right that a motor neuron disease causes if it affects all the muscles of the body, and it can even involve the muscles of the swallowing and also of breathing when it gets since it is a progressive condition, and I'm afraid it is not curable. With time it can involve all of these muscles, and in your wife's case also it might have affected her swallowing muscles, due to which some of the food particles tend to go into her air pipe as well from her food pipe. And when these enter the lungs, it can cause some soreness, and this can result in these recurrent chest infections that we call as aspiration pneumonia.
Okay, doctor, is it critical condition?
Well, Mr. Webster, if left untreated, it can be critical. And so we have to manage this and try to prevent this from happening in the future.
And how would you do that, though?
Are you following?
Yeah. How would you do that?
Our team has decided on a certain treatment for a certain management plan for your wife. But before I go on to that, I would like to ask you some questions about your wife, if that's all right.
Yeah, sure, doctor. Go ahead.
May I know that who else is living with her at home?
Only me and her, doctor.
Okay, and how is she managing at home? Are you able to manage? Are you both able to manage her with her health condition?
Yeah, doctor, I've told you that her health it's like declined and it's worse now. However, I'm trying to support her. I'm trying to manage the situation with her, but sometimes it's a challenging, doctor.
Okay, I appreciate that you're helping your wife. And let me assure you that if it is difficult, I can only imagine that it must be difficult for you alone. So we can arrange some social services in that regard who can also assist you in her care. Would that be fine?
Thank you, doctor.
Okay, and may I know, is she smoking?
No, doctor.
Or is she drinking alcohol?
Yes, doctor.
Okay, may I know how much over a week?
Well, she never exceeds the limit, doctor. She's just drinking 5 to 6 units a week.
All right. So, Mr. Webster, let me get to the management plan. What our team has decided. We feel that it would be best for her to undergo a procedure which we call as a PEG tube, which is a percutaneous endoscopic gastrostomy. Sorry, it's a complicated name. Have you heard about it?
Yeah, doctor. No, ever. It seems really long name and complicated name. What kind of procedure is that?
Okay, well, Mr. Webster, what we'll do is that it is actually a procedure in which we make a small, we insert a tube through the skin, and with the help of a small cut, we insert it directly into the tummy, through which directly feeding can take place, so that we can bypass the food pipe and the air pipe, so that the food does not enter into the air pipe when she's trying to swallow her food.
Oh, doctor, it seems something awful. Are you going to cut her tummy just to feed her throughout an opening?
Well, Mr. Webster, your concern is very valid. It might seem awful, but I want to explain to you in more details how we'll be doing this. Can I do that?
Yes, please, doctor.
Okay, well, before the procedure happens, what we'll do is that we will arrange a meeting with the doctor who is going to do this, who has done this many times before. Then what we'll be doing is we'll run some specific tests on her. We'll take and we'll ensure she's not taking any blood thinning medications. And we will see that she is completely fit for this procedure before doing it. And her consent will also be taken if she's willing to undergo the procedure after learning about it in more detail. And she can withdraw this consent at any time if she feels so. Next, what we'll do is that if she agrees with the procedure, she will be called to a clean room called the operation theater, where, with the help of a camera test, we will properly numb her skin, and a very small cut will be made. It's a very thin tube, and this will be inserted directly to her tummy from there. And we will ensure that it is a pain-free, as much pain-free as possible. And sir, there are, as you know, every procedure has some risks. Although it is the benefits are far more, but there are some risks that I want to tell you about as well. Mr. Webster, are you following me so far?
I'm following you, doctor, but just to be honest, I think that you are not expert enough to explain such management plan for me. Please, I'd like to speak to your consultant.
Mr. Webster, I appreciate your concern. I can definitely arrange a meeting with my consultant also. But may I know that why you feel this way? Have I missed something that you want me to explain more?
No, doctor. You seem like so young to know all of these things regarding my wife's condition. It's a rare condition, and you are explaining something which is really invasive, and you are just trying to convince me that this is the solution for her chest infection. And I cannot see any correlation between incision in her tummy and the chest infection. So I need to speak to your consultant, doctor.
Okay, Mr. Webster, I can arrange that. But I would just like to explain to you a bit more that, like I said, that when your wife is trying to swallow her food, since the swallowing muscles are weakened by this motor neuron disease, the food particles tend to go into her windpipe and into her chest, causing these infections. So this PEG tube, what it does is that it prevents food from being taken into the mouth. We can give her food directly into her tummy. So in that manner, we can avoid these chest infections, which, like I told you, if they are recurrent over the longer run, they can be life-threatening for your wife. They can affect her breathing, they can cause scarring of her lungs, and they can affect her breathing, and that can
I
be
will never let her go through this, doctor.
Okay, Mr. Webster, I can see that it's distressing for you to know the management plan that we've decided. But can you tell me why what's concerning you, why you are not
I
agreeing to
think
the
this is
procedure?
something really invasive for her condition. And she will never be able to manage this. 2 minutes remaining.
Okay, Mr. Webster. This is a kind of a minimally invasive procedure in the sense that we exactly locate with the help of a camera tube, which will be passing into her tummy. We exactly locate where we will be inserting the tube, and it's a small cut that is going to be made. So it's important that we save her lungs and prevent this infections from happening. Otherwise, they can damage her lungs. So that is why this is the best management.
Yeah, if you are going to do this procedure, doctor, do you think that she's going to be okay, doctor?
Well, Mr. Webster, I can see that you're very concerned for your wife, and that's appreciable. Like I told you, it's a progressive disease. Motor neuron disease is, I'm afraid, so sorry to tell you, it's not curable. But we can have these procedures to help control her symptoms and make her quality of life as best as we can.
Am I losing her, doctor?
Yeah, that I appreciate your concern. Well, it is in the longer run, the disease tends to be progressive and it can cause a lot of complications. But let me assure you that we are going to manage her symptoms as best as we can uh, and support her in this journey. Mr. Webster, may I know if you have any other concerns? No, doctor, that's fine. Okay. In such conditions, because it is a progressive condition, usually a lot of patients have advanced directives and lasting power of attorney, so that who can decide on their further management in the
Time
future.
up. Okay, you can continue, but just keep in mind that time up.
Okay. So a lot of patients do have these so that they can take decisions on their part when they cannot in the future. Does your wife have any such advanced directive or lasting power of attorney?
Yes, doctor. I'm not sure what's lasting power of attorney is, but I think that she made her advanced directive already that she doesn't want to be resuscitated.
Okay, I respect her decision. Well, lasting power of attorney is a person who is appointed on behalf of the patient, who can take decisions regarding her health in the future. So if she wants to assign anybody, that can be done.
Okay.
Is that fine? Okay, Mr. Webster, thank you for.
Thank you. So, doctor, what's your scenario about?
My scenario is that I have to talk to the husband of Mrs. Sally Webster, who is already a diagnosed case of motor neuron disease, now having a complication of this condition in form of recurrent chest infections, and the diagnosis of aspiration pneumonia has been made. So I have to counsel him regarding PEG tube insertion for this prevention.
Brilliant. How do you think your scenario went?
Mr. Webster was a bit reluctant. Although he knew about motor neuron disease and he had done his research for regarding why the chest infections were happening. He was a bit reluctant about the PEG tube. I tried to convince him regarding that it will be life-saving for his wife. It will prevent damage to the lungs. I think I managed to convince him a bit by the end, but it would be better to have the patient as well in another meeting further discuss.
Okay, fair enough. So, I need from you yourself, Dr. Kumal, to assess your skills.
I think time management, because he wasn't convinced. So
do you think that the time management one of the skills? So let's start with our skills. What do you think about your clinical communication?
I think it would be borderline.
Okay, no, you've managed well. You've got very good mark in the communication skills. What about the patient welfare?
I tried to manage the patient welfare. I discussed about her help at home. I discussed that we will do tests and to see if she will be fit for it. I discussed about consent. So I tried to manage her welfare.
Fair enough. So you've got a good welfare skill. What about your clinical judgment?
For judgment, I discussed that we will rule out any blood thinning medications before doing this procedure. And also we'll do the blood test. And I told him it's a progressive condition and she may get worse in the future. So she should have an advanced directive or lasting power of attorney.
Okay. So the point here within your clinical judgment, your clinical judgment, Dr. Kumal, within this scenario severely affected. Why? Starting from the beginning, he told you that I made my research regarding this, and I think it's because of the respiratory muscle affection. This is only a piece of truth. So it could be because of respiratory muscle, it could be because of swallowing muscles. You've mentioned that later on, after you've convinced him that you are totally all right. No, you've got missed part, Mr. Webster, which is affection of her respiratory muscle and swallowing muscles, and this is the main problem. Okay, I wasn't sure how to convey to him that it's not as we had hoped, or you are partly. I wasn't sure how to break it. Okay, let me do seconds. Okay, so Dr. Kumal, we've agreed when you are going to explain any new diagnosis for the patient, what is the main part to get full communication? It's a drawing. Yes. He doesn't know the anatomy. He's not a doctor. Relation between the food pipe and air pipe. You've kept telling him that because of weak swallowing muscles, some food particles go for the air pipe. He doesn't know where is the air pipe is. Okay. So this is the point, and that's why he told you, I don't think that there is any correlation between opening her tummy and her chest infection, doctor. He was trying just to push you, doctor, I don't know the anatomy, to explain any new diagnosis. You've done something which is really smart. Most of the candidates who practicing this case, they tend to explain the motor neuron disease. No, the motor neuron disease, it's not the diagnosis here. The diagnosis is aspiration pneumonia. Your job is to explain the aspiration pneumonia and the cause for it. The second part, why your clinical judgment affected, you didn't mention the most important complication So you've mentioned recurrent chest infection, chest scarring, and so on. You didn't mention that she's susceptible for bacteremia, septicemia, and death. This is the main thing.
Okay.
Does it make sense for you?
Yes, doctor.
Okay. So when you are going to explain any new diagnosis, what's your approach? So please, Dr. Muhammad, please mute your mic. So, Dr. Kumar, when you are going to explain any new diagnosis, what's your approach?
I would tell them about the pathophysiology or definition, the signs and symptoms,
so
and
the
complications.
physiology, just one by one. The physiology, it's something really important because you are dealing with someone who doesn't know the anatomy, who doesn't know the physiology. How to explain the physiology and the anatomy? By drawing. As simple as that. And this is the most time-saving approach. Okay, so the first step to explain new diagnosis would be the physiology, which is method here. The second step is
then the signs and symptoms.
Okay. No, the cause of this condition. If there is any cause, and most of the times the cause including the definition. Like if you are going to mention, I'm really sorry to tell you that you have been diagnosed with a condition called hypertrophic obstructive cardiomyopathy. Let me draw you a drawing. This is your heart. This is the normal barrier separating your heart chambers. So this is the physiology. After the physiology, we've got the cause and the definition. So this is a familial condition, runs in families from one generation to the next. So at the same time, I've defined the condition and I've given the cause. So here, it's a chest infection. The aspiration pneumonia, it's a chest infection, which is caused by the weak muscles due to motor neuron disease. Okay, so the first step is the physiology. The second step is the cause and definition. The third step, Dr. Kumal, is the signs and symptoms. Most of the times, if I've got a very long scenario like this, because I'm going to explain the big tube later on, so still I've got tasks, there is no time to mention the signs and symptoms of aspiration pneumonia, like shortness of breath, cough, fever, patient, he will feel unwell, and so on. There is no time to mention all of these things. I'm going to mention only one sentence, which is the signs and symptoms typical to her presentation. Now I feel that you've got a clear approach and you are organized. After the signs and symptoms, Dr. Kumal?
After that, the complications.
The complication. And the complication critical in station 4. So you have to mention the complications. Sometimes we've got lots of complications and we don't have time to mention all the complications. Dr. Kumal, I'm going to forgive you if you missed the lung scarring because she has motor neuron disease. She has progressive disease. Even if she got fibrosis or tractional bronchiectasis because of this aspiration pneumonia, it's not going to change nothing from my prognosis. But if this patient, one of the chest infection, she got ARDS or she got septicemia, we are going to lose her immediately. Am I right?
Yes, doctor.
So this is the point. When you are going to mention any kind of complication, think about with the most serious complication, the complication that may change the patient's life or may change my prognosis and treatment as well. So the complication here, you have to mention that it could be very severe, leading to inability for her lungs to breathe anymore. And this bugs, it could be circulating throughout her body, leading to some organ damage, and we may lose her. I'm really sorry to tell you that. When you are going to mention the complication, the most serious, the serious complication for your patient or for the patient's relative, what's going to happen? He's going to be easily convinced regarding your management plan. Because when you are going to mention your management plan, what you are telling him that this is management plan to prevent these very bad, or those the bad complication, I mean. And did you get that, Dr. Kumar? Hello? Can you hear me,
Dr.
guys?
Ella? How do we tell her about the ARDS?
Okay, so her lungs may be severely damaged.
Hello?
At one of the chest infection. Yeah, can you hear me, guys?
Yes.
Guys,
Yes,
is it
doctor.
from my side or from Dr. Kumal's side?
No, for your side is okay. We are
Brilliant. Thank you, Dr. Huda. Thank you, Dr. Sanam. Hello, Dr. Kumal. Seems that we've lost
Your
you.
voice is broken.
It's from your side. I'm sorry to tell you that.
We can hear.
Hello?
No, I cannot hear anyone's voice. Only your voice is clear.
We can hear you.
Sorry,
Dr. Ala,
Dr.
please
Hassan.
continue. Yes, your voice is clear, ma'am. No problem.
Oh,
Continue, ma'am.
thank you. Just I'd like Dr. Kumal to listen to the answer for her question. So how to tell the patient about the RDS? One of the chest infections, it could be so severe for her lung, leading to inability of the lungs to breathe anymore. You are not going to explain the ARDS in details. So this is a severe damage of the lung. So there is a very tiny border between the severe lung injury and ARDS. You don't need to explain the numbers. You don't need to explain that the possibility of the edema and things like this. Just mention severe chest infection with the damage of the whole lung, and the lungs wouldn't be able to breathe anymore. Is it clear so far, guys?
Yes, doctor.
Okay, brilliant. So after that, so our main approach, let's agree that we've got 5 steps here. The first step is the introduction. The second step is explaining the new diagnosis, which is aspiration pneumonia here. The third step would be the history. The fourth step would be explaining PEG tube. And the last step is closure and concern. So we've covered already how to explain new diagnosis, starting with the normal physiology, then the definition and the cause, signs and symptoms typical to her presentation, complication, the most serious one. After that, the history points. So what are the very important history points that you have to ask in such scenario, Dr. Kumal?
Dr. Ella, I was not sure about the past history or medical history. I just asked the social history because I felt that was only significant help at home over here.
Okay, brilliant. So asking who's the one who's taking care of her, and asking whether she can manage her daily activities or not, and whether you need any kind of help regarding this or not. Then, is it something strongly relevant to ask about smoking and alcohol? I know this is a chest infection, but do you think that someone with motor neuron disease, you would be able to smoke? Anyway, it's not a mistake, and it's not something really important to ask. So you can ask, you can skip that. But the most important things to ask here would be the end of life issues. Because you've mentioned the end of life issues, Dr. Kumal, once you've got 13 seconds left. And this is critical. Why?
Dr. Ala, would we discuss them before the management plan? Because that would aggravate him, that is dying.
Okay, brilliant. I'll let you know the answer. The point is why we need to discuss, why we need, or what's the urgency to discuss such points, because it's going to be your legal issues in this scenario. So if you've missed them, you are going to leave the station and you know 100% that you failed the clinical judgment here. This is the first point, to save yourself. The second point is, you are going to go for a procedure, Dr. Kamal. If the patient got advanced directive, do not operate. Is it something relevant or not?
Yes, in that case, it would be relevant.
Okay, your patient got aspiration in pneumonia, and she's 55 years old. One of the manifestation of pneumonia, it could be confusion. If she's confused, do you think that you are going to take the consent from her husband or not? What do you think, Dr. Kumar?
Yes, we take the consent from the lasting power of attorney.
If he has the lasting power of attorney. So here, raising the points of advanced directive and lasting power of attorney before your management plan would be really valid. Doesn't make sense.
Can you take consent from next of kin as well, or is it important only for lasting power?
So, brilliant question. And we've discussed that, guys, previously. So we've agreed for any elective procedure, next of kin has no right to sign it.
Okay.
So PEG tube, it's elective. Do you think it's an emergency?
No, it's not.
So if he's the next of kin only, he doesn't has the right to sign the consent. Okay? So here, within your question, the most important part would be the social part and end-of-life issues. And please, most of the doctors, Dr. Kumal, especially in the recent DIE, the first DIE 2021, they consider advanced directive and lasting power of attorney as a jargon. I've got multiple feedback. So please, when you are going to ask, did she express any wishes regarding her health, how she would like to be treated? This is the first thing. And did she assign anyone to take a decision on her behalf while she is unable to do so? Okay? Do not ask advanced directive and lasting power of attorney, because you may lose mark from your clinical communication because you've mentioned jargon. Okay. So we've covered the history point. After the history point, we are going to explain the PEG tube. What are the steps for any procedures, Dr. Kumar? We've discussed that multiple times, guys. Yep.
Yes, we will tell what we'll do before the procedure, during the procedure, and after the procedure.
Nope, absolutely no. The first point, why we need this procedure, and what if not done? Okay, so why we need this procedure? To clarify more, to prevent this weak swallowing from giving her chest infection. You have to stress on that because he feels at some point that you are not expert enough. You don't know what you are speaking about. So why we need it? What if not done? She will develop multiple chest infection again and again. I'm sorry to tell you that. And one of them, it could be fatal. Then after that, go for before, during, and after. Okay? What then after that, before, during, and after? Within the before, what you have to make sure of. Dr. Kumal, can you hear me?
Yes, I can hear you. Within
Yeah.
before, we need to determine if she's taking any blood thinning medications, and we will do some tests to see if she's fit for the procedure.
Brilliant. So the title is whether she's fit for the procedure or not by doing some blood tests. And can I ask you, even if you didn't ask within the history, does she take any kind of blood thinning medication or not? No, doctor, she's not taking. So this is within the before. During the procedure, to explain the procedure, doctor, I don't have much information regarding the procedure. Whatever the procedure, PEG tube, lumbar puncture, bronchoscopy, endoscopy, chemoembolization, whatever the procedure, I'm going to explain very simple things. So within the PEG tube, we are going to introduce a camera throughout her mouth. And just to be sure that we are in the right place, we are going to numb the skin, clean the skin from the outside, and making small incision and introducing a thin tube, and it's going to be fixed there. We are going to take care of it while she's an inpatient, and we are going to speak about this later on. So, after the procedure, what is the point of after the procedure that you didn't mention for him? And again, you've lost marks from your clinical judgment.
Yes, I wanted to talk about the risks of the procedure and how we'll follow up and monitor her, but he didn't give me a chance to.
Okay, so the point is that after the procedure, I'm going to tell you why he interrupted you and why he didn't listen to you. So after the procedure, just to be sure that she will not suffer any complication. Okay. And you can mention who will do it and where. Who will do it? We've got rules, guys, in the clinical ethics and communication. Our rules, our fixed rules that I've mentioned in the previous session, I'm going to mention again today. No persons. Do not mention any person per se. No time frame. You've mentioned that a doctor who did this procedure will do it for her. What do you think about technician can do PEG tube? Dr. Kumal.
Yes, Dr. Allah.
Okay, so the technician can do the PEG tube.
No,
The sorry?
I don't think the technician will do it.
No, they can. Here in UK, the technicians can go for the PEG tube. And the point is, your general rule, do not mention person. So my general rule is team who did this procedure several times. So team and several times. It's not 100, it's not 1,000. Do not mention any numbers and places. Okay? So team who's expert and did this procedure several times will do it for her in operating room or inside room, clean room like operating room. Okay, So this is how to mention the procedure. So within the procedure, why we need it, what if not done, before, during, and after, who and where, or you can start who and where before, during, and after. After that, the complication. So you have to have a pause between the explanation and the complication. Do not mention the word of the complication unless you think that the patient would be able to listen to more information. He would be able to gather more from your side. Okay? So after you've mentioned all of these things, so the procedure is going to be done in small room like operating room. Team who's expert who did this procedure several times will do it for her. Before that, we would like to be sure that she's fit for the procedure by doing some blood tests and to be sure that she doesn't take any blood thinning medication. During the procedure, we are going to introduce camera throughout her mouth to be sure that we are in the right place. We are going to make a small incision after numbing her skin and cleaning the skin. And we are going to fix a thin tube there, and we are going to take care of that during her hospitalization. After the procedure, we will keep her for a while just to be sure that she will not suffer any complication. Then, what do you think, Mr. Webster, so far? Well, doctor, it seems really complicated. I really appreciate that, and be sure that we are going to explain everything for her as well. So you have to have a pause. You have to check the understanding between the explanation and the complication. Do not go directly for the complication. So, Mr. David, as any, or Mr. Webster, as any procedure, it carries risk of complication. However, it's really minimal in expert hands. I need to tell you about them anyway. Complication including failure of procedure, introduction of infection, bleeding, and so on. So the fixed complication. Leakage around the tube, and be sure that we can handle such complication. Okay? And after the complication, the alarming signs. After we will send her home, be sure if she developed any intractable pain at the site of the procedure, if she developed any leak around the procedure or bleeding, if she developed any raised body temperature, please be sure that you are going to seek medical advice as early as possible. And we will explain everything for her. We will obtain her consent, and she would be able to read the consent carefully, sign it when she feels ready, and she has the right to withdraw the consent at any time. These are the criteria of the consent. So this is how to explain all of these things. Doctor, I think that the time, it's not enough to do all of these things. If you've got structured approach, you can do all of these steps. It's not one of the longest scenarios. We've got longest scenario than this one. Okay, so we have to manage our time. After mentioning all of these things, and expect all the time the patient will interrupt you, will ask you many questions. Doctor, you are not expert enough. Can I speak to your consultant? What's the answer for this concern, Dr. Kumal?
It is his right to talk to the consultant, but I still try to find out why he felt he needs to talk to the consultant.
So who's the consultant, Dr. Kumal? He's your consultant. So you are one of his team. You have to mention that for the patient. And they love the teamwork job. We are working as a team, and be sure that the consultant will tell you the same. However, this is your right to meet him. Did you get that, Dr. Kumal?
Yes, I got it.
You have to show some confidence and you have to defend yourself in polite way, and you have to raise the point of the teamwork. They love this concern. Why? Just to know whether you are part of the team or not. Okay? Then, the other question. Do not ask him, why did I miss anything? It seems for me that you are hesitant.
Maybe he felt my explanation was written.
Nope. I feel that you are hesitant. You are going to review your information, which is wrong. They need to clarify the point of working in a team, okay, or teamwork. Then, the second concern, doctor, am I losing her? How would you answer that?
That would be the same. Yeah, the same. I appreciate your concern. It is a progressive condition, and it is not curable. But let me assure you that we are here to support her and give her the best management plan.
Great. So our game, our communication game, which is appreciate, piece of truth, and reassurance. Okay. So, doctor, is she going to be okay? Give me any hope.
This will be the same answer.
The same game, which is appreciate the piece of the truth and reassure. So, take this concern. Doctor, who's going to take care of this tube?
Okay, that is a very valid concern. What we can we'll do is that we will involve our specialist nurses. And we will also involve you in our meeting along with Mrs. Webster. And together we'll tell you in detail how to take care of this tube. And if any complication arises, like any leakage from the tube or any bleeding, then you can come immediately to the hospital and we can manage that.
Okay. So you've got very long answer. I'm sorry to tell you, it's not conclusive. So how to answer this concern for any procedure? Your patient, you will send your patient with a PEG tube home. You will send your patient home with a Hickman line. You will send your patient home with nephrostomy tube. So who's going to take care of this tube, doctor? You've got 3 parts. During the hospital stay, our nursing staff. After discharge or soon after discharge, the district nurse. We will send a district nurse for you to take care of the tube and to train you how to take care of it yourselves. After a while, you would be able to do it yourselves. Okay, so this is the answer for anything. PEG tube, Hickman line, nephrostomy tube, whatever, artificial limb, anything. Wound, who's going to take care of it? During hospital, the nursing staff. Early after discharge, district nurse, and she or they will train you how to do it yourselves. After a while, you would be able to do it yourselves. Is it clear so far, Dr. Kumal?
Yes, doctor, very clear.
Okay, brilliant. So the main thing is have a very clear approach. Our approach here, just before entering the station, introduction, explain aspiration pneumonia, history, explain the PEG tube, and closure. Then you have to write this in your paper. If you didn't write this, the patient or the relative will ask you many times, will interrupt you, and you will lose the track. Okay? Then, I've got a tiny comment regarding your introduction. Hello, I'm Dr. Zahid. I'm the doctor in the tummy clinic. It's not the tummy clinic, it's the gut clinic. Okay. Then Yeah.
Dr. Anna? Okay.
yeah.
Yes, please.
Yeah.
But I did not know how to, like, he was partly correct about the what was causing the recurrent chest infections. So I was not sure how to start. Like, should I say yes, it is as you had hoped?
Exactly
I
like
was
you've
not sure about the
mentioned.
opening line.
So exactly like you've mentioned, you are partially correct. As simple as that. I really appreciate your search, and you are partially correct. Yes, it's because that her respiratory muscle weak and affected, but the main point is that her swallowing muscle is affected as well. Let me draw you a drawing. This is her food pipe. This is her air pipe. Both of them really close to each other. When the swallowing muscle affected, the food particles going to the air pipe rather than going to the food pipe, giving her the chest infection.
Okay.
Is it clear now?
Yes, Dr. Ella.
Okay, brilliant. Any other question, Dr. Kumal?
Yeah, no, it's clear for me.
Okay, great.
In the introduction, just my tummy thing.
Yeah, it's not a tummy clinic, it's a gut clinic. Okay? Yeah, just before opening the door for the question, guys, just I'd like to wrap up the whole scenario. So simply, how to approach such case, starting with the introduction, the normal, the usual introduction. Sorry, breaking bad news, starting by explain the normal physiology, the definition and the cause, signs and symptoms, including the complication, and all of these things supported by investigation that we've investigated her, and we've got that she has aspiration pneumonia. Social history, the main points here of the social history would be end of life issues. This is the main part. The social history was taking care of her. You can ask about blood thinning medication here. You can keep this to the explanation of the PEG tube. Then explaining the management plan, all the steps of counseling on procedure. What are the steps? Why we need it? What if not done? Who, where, before, during, and after. Then we are going to follow up her complication, if there is any alarming signs, and precautions if there is any precautions. With the PEG tube, it's just a specific feeding, and she's going to have semi-liquid food. Then the consent. Who's going to go for the consent? Is it Mr. Webster or Mrs. Webster? If she's competent, she's the one who's going to sign the consent. If she's not competent and he has lasting power of attorney, he can sign the consent. Recap and close at the end and check the understanding all the times. Dr. Kumal, if I'm going to ask you, what are the legal issues in this scenario?
The legal issues would be the advanced directive and lasting power of attorney, and capacity as well as
capacity.
Consent.
Great. So this is the main point, is the capacity. So the legal issues would be lasting power of attorney, would be advanced directive, consent, and the most important thing that you have to mention is the capacity. What would be the possible concerns in such scenarios, guys? So simply give me hope, doctor. Is she going to be okay, doctor? Am I losing her, doctor? Is she going to die, doctor? Is she in a critical condition, doctor? All of these concerns got the same management or the same answer. What's the same answer? Our communication game, which is reassure, piece of truth, and appreciate, piece of truth, and reassure. Please give me the name of the consultant. You are not an expert, doctor. Okay, so give me the name of the consultant. You are not an expert, doctor. Simply, this is absolutely your right, and be sure that we are working in a team, and my consultant will tell you absolutely the same. So, is she going to be okay? The same. Give me a hope, doctor. I will not let her go through this. Can I know why? Try to fax why he's refusing the procedure. I think it's really invasive, but This is may save her life. Again, stress that one of the chest infections, it could be fatal. And be sure that we are going to discuss this with her and we are going to obtain her consent. Am I going to lose her? The same answer, guys. So these are the possible concerns in such scenario. So is there any question? Seems that the chat box blowing. Yeah.
Dr. Alaa, please.
Yes, Dr. Ahmed.
Regarding the capacity of this patient, I think he is motor neuron disease since 5 years, I think. So I think the capacity should have been affected, or we have no news about the capacity. So how we decide that?
We don't.
Yes.
Brilliant question, Dr. Ahmed. First of all, let's agree that the motor neuron disease will never affect the patient capacity and the patient higher mental function. So it's not related at all. If her capacity affected, it's going to be affected because of the pneumonia, because the pneumonia can give her confusion.
But I think there is a relation between the frontal dementia. It's correlated with motor neuron disease, usually associated with motor neuron disease.
Brilliant.
Yes.
Brilliant, Dr. Ahmed. However, we are thinking, or we are speaking about the commonest common. We are not speaking about the rare associations. Okay? So usually the motor neuron disease, their mental illness, it's not affected. However, we are not going to guess. It's not our guess. How to assess the capacity? Do you think that she's competent enough to decide or not, Mr. Webster? As simple as that. Yes, doctor, she is. Oh, brilliant. We are going to discuss everything with her. Well, doctor, I'm not sure whether she's competent or not. Be sure that we are going to have a special team to assess her capacity to decide. Okay? So do not guess, do not think about the rare or the common here. Simply ask.
Okay.
Is it clear now?
Yes, thank you.
You're welcome. Any other question, guys?
Yes, please, doctor. I didn't get the part you said about consent in elective procedure.
Okay, so Dr. Kumal asked me if he's the next of kin, he would be able to have a consent or not. So we've discussed this thoroughly previously, guys, and let me repeat this. The decision maker, we've got the patient himself. We've got something called advanced directive. We've got the next of kin, and we've got the lasting power of attorney. Let's apply this on certain examples, or let's just think about these makers in order. Who has the right to decide upon any procedure? First of all, the patient himself. Well, I don't know I don't want a big tube. This is my right. I'm the patient. After that, if I've got any advanced directive, if I'm confused now and I have advanced directive, I've written, I don't need any procedure, I don't need any operation. So this is my wish, this is my willing. So you have to respect this. So by order, the patient himself, and equal to the patient himself, his wishes, I mean the advanced directive. After that, the lasting power of attorney or the medical power of attorney. What is the lasting power of attorney or what's the medical power of attorney? This is someone that you can give him the authority to decide when you are unable to decide. This is something legal, has to be written. So I'm not going to mention. So who's the doctor who asked me? I think Dr. Marwa. Am I right?
Yes, doctor.
Okay, great. So if I'm going to mention, if I'm confused or I am in coma, I need Dr. Marwa to take the decision on my behalf while I'm unable to do so. So it's not something legal. I have to write this. I have to sign this. This is the lasting power of attorney or the medical power of attorney. And this lasting power or medical power of attorney has the authority to decide on the health issues, like go for the procedure, do not go for the procedure, and so on. The last one is the next of kin. Next of kin means someone who has a blood relationship. Your brother, your sister, your mother, your father, plus your husband. Okay? So, do you think that your next of kin has the right to decide whether you are going to go for the PEG tube or not? If it's an emergency, he has the right to accept, not refuse. Like, if the patient presented to the A&E with ruptured spleen and he's shocked, either you are going to open laparotomy him or not. He will die. If the next of kin told you do not go for the procedure, you are not going to listen to him. If the next of kin tell you, doctor, go for the procedure, just take his consent. So the next of kin can consent in the emergency by positive, not by refusing. If such case, her husband only next of kin, he doesn't have the lasting power of attorney, and told you, doctor, go for the procedure, do the PEG tube. I'm sorry to tell you, he doesn't have the right, because this is not an emergency. Did you get that, Dr. Marwa?
Yes.
Is it clear now?
If the patient is not competent, he still don't have the right to accept or refuse.
So if the patient competent, Dr. Marwa, he doesn't the right, the relative
It's
doesn't
not
have the right. So if you are going to reach the next of kin, 100% that your patient is not competent. If he's competent, why you are going to ask the next of kin?
No, I am asking if not competent. Yani she is not competent. He has the right to accept or refuse, or still don't have right.
I've got your point, but you didn't get mine. So, Dr. Marwa, simply, if your patient competent, you are not going to reach the next of kin. If your patient competent, انت مش هتبصي للnext of kin اساسا عشان هو قادر انه يديسايد. فلو انت وصلتي للnext of kin 100% your patient is not competent. So when I'm mentioning the next of kin, so presumably your patient not competent. He's not competent. What I've discussed, I mean the patient not competent. Did you get that?
يعني next of kin has the right to accept only emergency.
Yes, that's it.
Okay. شكرا.
عفوا. Any other question?
Ma'am, I have a question. If it is asked that are you the next of kin, and if the patient, the surrogate says, no, I'm not the next of kin, is it possible that they can say like this?
Okay, so, sorry, who's asking?
Dr. Said.
Okay, so Dr. Said, so assembly, we've agreed that we are not going to ask the patient, are you the next of kin? Because this is something that I can know. It doesn't make sense that I'm going to ask your wife, Dr. Sayed, are you the next of kin for Dr. Sayed? Of course she is.
Okay.
I'm not going to ask your brother, are you the next of kin? Of course he is.
Okay.
So the next
So
of
if-
kin,
if-
it's not something
yes,
that we
yes.
are going to ask. The next of
Yes.
kin, what we are going to ask, are you the carer? Are you the one who's taking care of him? Because the carer, I'm not going to make things complicated, guys. The carer has a slot in our decision making, and the medical team has a slot in the decision making as well. However, you are not going to ask anyone, are you the next of kin? Ask him, are you the one who's taking care of him? Because if your brother, he's the next of kin, no doubt. But it doesn't mean that he's the one who's taking care of you.
Yes.
Did you get that, Dr. Said?
Yes, I got your point. Thank you.
You welcome.
So we won't ever ask about the next of kin. We just ask, are you the caregiver or who is giving care
Yes,
to this patient?
exactly. Are you the one who's taking care of him or not? And are you the one who has the lasting power of attorney or not? Because the lasting power of attorney, it could be my friend, it could be my neighbor. It's not something necessary to be one of my blood relationships.
Okay. And the other thing is,
Yep.
yes, yes, ma'am. And the other thing is, the next of kin will be just a listener in elective procedure. But in case of emergency, he can give positive consent for the procedure.
He can give positive consent. And here, why I've told you that the medical team has a slot in the decision making as well, because the medical team has the authority to decide in the emergencies. So if there is an emergency and I don't have next of kin, I don't have lasting power of attorney, and the patient incompetent or comatose, I'm the one who's going to take the decision. So the medical team has a slot in the emergencies as well.
Okay.
Okay.
Okay. In emergency and in elective also.
The medical team has no rule in the elective.
Oh, okay, I get it.
Okay.
I understand.
And even I'm not going to make things complicated, guys. Even within the emergency, the upper hand or the higher hand for the patient's decision, it's not for the medical team. Like the resuscitation, is it something emergency or not, Dr. Said?
Yes.
Okay. If the patient expressed his wishes that he doesn't want to be resuscitated, are you going to resuscitate?
No, I will respect the patient decision.
Exactly. So the higher hand or the upper hand almost always will be for the patient. After the patient, it depends upon the situation.
Okay. I got it. Thank
clear
you.
now?
Thank you. Yes.
You're
Thank you.
Yeah. Yes, Dr. Sana.
Assalamu alaikum, ma'am.
Walaikum salam.
Just wanted to ask, if patient has verbal living wish or verbal lasting power, will it weigh the same or is it not important?
Well, you will never face such cases in the PACES, which is the gray zone. However, within the real life, it needs legal expertise. And you are not the one, you are a doctor. Okay? So they got some criteria to accept this, which is presence of two witnesses and things like this. However, it needs legal expertise to decide, and it's not your task.
So patient's relative can't say that I have verbal lasting power. It's not comes in cases like this, right?
So I'm going to raise the issue for the legal expertise doctor.
Okay.
Okay?
Okay, ma'am.
Any other question, guys?
Dr. Ala.
Yes, Dr. Ismail.
Dr. Nala, for last power of attorney is the same applied as an next of kin in emergency?
Sorry, I didn't get your question.
Last power of attorney is the same applied as a next of kin in emergency? We cannot follow if he's refusing emergency treatment?
Yes, absolutely yes. So that's why I've told you in the emergency, the patient has the upper hand all the times, and within the emergencies, the medical decision has the upper hand.
Okay, that's the mean upper hand, advanced directive and the patient, huh? Both.
Yes, so the advanced directive equal the patient, Dr. Smile.
Thank you too much, thank you.
You're welcome.
Doctor, still, I'm sorry, still something confusing to me. Big tube is elective, right?
Of course, big tube is elective. Do you think that if the patient didn't insert... So when you are going to mention emergency, Dr. Marwa, emergency means something if you didn't react within 2 minutes, you are going to lose your patient. This is the emergency.
Okay.
Or let's be more flexible within few minutes. So the big tube, you can insert the big tube now, you can insert the big tube after 1 month. This is not going to change anything from her condition. Just to prevent further chest infection. You don't know the next chest infection would happen within 10 days or would happen within 10 months. So this is completely elective.
So consent here should be signed from patient, right? Not
From the patient or lasting power of attorney.
Okay. Yeah, not related to the husband here. As a legal issue, not
what do you mean by the husband? We are not dealing with husbands. Do you mean next of kin?
Yes, in scenario, he was the next of kin was the husband, right?
So the husband here, we don't know whether he has lasting power of attorney. If he has the lasting power of attorney and the patient not competent, he can sign the consent. But here, the patient competent.
Okay. Yeah, still consent is legal issue here. Still
yes, legal issue, but who's the one who has to sign the consent? The patient.
The patient. Okay.
Yes.
Dr. Ala,
Yes, Dr. A.H.
about the same issue, here it is elective procedure. If the patient is not competent and he has no lasting power of attorney, so the medical team gonna decide about the big tube?
Unfortunately, no. The medical team has no right in the electives. So what they are going to do, again, you have to raise the issue to the legal authorities. So the patient, she's not competent, has no lasting power of attorney. However, she got next of kin. Shall we take the consent from the next of kin or not?
Okay, so legal advice first, and then we will decide who will consent. Okay.
Yes, exactly. But the medical team has no right in deciding in the elective procedures.
Okay.
Dr. Ella, sorry to bother.
Yes, Doctor.
So, in this case, husband has no right to refuse, is it? Or
no, has
like
no
we are just
right.
Explaining the situation, like.
Yeah. So you are explaining the condition for the patient just to update him, and he got already the consent, presumably he got the verbal permission to discuss the case with you. However, he has no right to refuse. So the point is, do you think that your wife is competent? I'm not sure, doctor. So we are going to assess her capacity, as simple as that. Is it clear, doctor, then?
Okay. Yeah, thank you.
You're welcome.
Yeah, it's clear, madam.
Brilliant. Thank you. Hopefully this is answering your question. Any other question, guys?
Yes, ma'am. I have a question. This lasting power of attorney and a living will. These are the same?
No. So we've got something called advanced directive and living well. What's the difference between advanced directive and living well? Lasting power of attorney, it's something completely different. So lasting power of attorney means that I'm going to assign someone to take a decision on my behalf. This is the lasting power of attorney. So lasting power of attorney is the same medical power of attorney. But the advanced directive and living well, some of the candidate confusing between both of them. So advanced directive means that I'm going to express my wishes regarding my health only, health decision only. Like, I don't want to be resuscitated. I don't want any kind of procedures. Please do not insert any urinary catheter while I'm admitted. So all of these things related to my health. So I'm going to express them, and the name or the title of these things, advanced directive. Living well, this is something related to my money and properties. After death, I'm going to provide, or I'm going to give my flat for my husband. Sorry, Dr. Sami, please mute your mic. Dr. Sami Isam. Okay, sorry. Yeah. So living well means anything related to the money and properties. So I'm going to donate my flat for my husband. I'll donate my car for my brother. I'll donate my bank account for my mother. So this is the living well. Is it clear, Dr. Said?
Yes, it is clear.
But I thought that living will is for both finance as well as health. Living will, you said, is only for finance, or it can be both medical and finance?
No, only for financial issues. And by the way, this question was my own question on my own exam. What's the difference between advanced directive and living well? Okay?
Yes.
Yeah. Any other?
Yes, sometimes what happens, like a scenario, the patient, I have to ask the patient, did you took permission from your wife or your patient? Is it mandatory to ask something like that?
So it's not mandatory. Why? Because if he's the carer, if he's the one who's taking care of her, he has lifelong permission to speak about anything related to her health. And he's the carer here.
Okay, in case he's not the carer, but
he's not the carer, yeah. So do you have any verbal permission to speak about her condition? Yes, doctor. I've just spoken to her and she told me you can discuss the case with the doctors.
Okay, so do we need to ask this question?
If he's not the carer, yes, it's better. Just to save the confidentiality issue.
Yes, confidential issue. So we will ask whether you are the carer or caregiver. If he says yes, I'm the caregiver, then it is okay, nothing to ask. But if he's not the caregiver, then I will ask whether you have you took permission from your patient.
Yeah, and I prefer Dr. Sayed to ask about this since the beginning. Hello, I'm Dr. Al-Hashmi. I'm the doctor in the clinic today. Can I confirm that you are Mr. David, the husband of Mrs. Sally? Yes, doctor, I am. Are you the one who's taking care of her? Yes, doctor, I am the one. So no need to ask about the permission. No, doctor. Her daughter, the one who's taking care of her. So, Mr. Webster, do you have a permission to speak about her condition today? Yes, doctor, I've just spoken to her and she gave me the permission to speak to you.
Okay, great. Thank you.
Brilliant. Thank you.
Ma'am, if the patient comes to ER with a life-threatening condition, but he refuses the treatment.
Absolutely his right. If he's competent, absolutely his right. And by the way, let me tell you my own experience in such scenario. Patient last 2 weeks, who has a platelet count of 4. So he has platelet count of 4. He's refusing admission. He's refusing any transfusion. He's refusing any medication or treatment. So he's completely competent. This is absolutely his right. As simple as that. Is it clear now, Dr. Hashim?
Yes. But once he loses his consciousness and he's not competent, then we can proceed.
But if the patient expressed that previously, that he doesn't want anyone to treat him, you are not going to treat him while he's losing his consciousness.
But what if he has not written anywhere? It's just a verbal he says and then he becomes unconscious.
Legal expertise again, Dr. Hashim, and you know that. You've listened to that, you and your staff. So, absolutely his right.
Okay, thank you. Thank you so much.
You're welcome. Any other question, guys?
Dr. Ella, sorry. You just described one scenario. In this case, patient sign any document like, okay, I don't want any transfusion. So, do you need any legal like paper? Should he sign, like so that DNR type or something?
Sorry, doctor. Then I've lost my connection for a while. I didn't get your question. I'm really sorry for that.
I'm sorry.
Would you please repeat?
Dr. Ella, I'm asking that you described one scenario just now, right?
Mm-hmm.
So if patient refuse treatment, do you sign any paper like a DNR or something like, okay, you need to sign this now because you may deteriorate anytime? So,
no. What you are going to do, just you have to write note in his medical records. You are not going to let him sign anything.
But we have a paper refusal for treatment in hospitals.
Okay.
Well, to be honest,
thank you, Dr. Ella.
You're welcome. In my department, we are not giving the patient any refusal form for the treatment.
Okay.
Dr. Ali, if this patient is arrested at that time, you do CPR or you do everything?
Sorry, Dr. Omar?
This patient has platelet 6 if he's still conscious and arrested in the ER.
Yes.
We can do for him CPR or not to do?
Yes, you are going to resuscitate him. The patient doesn't refuse the resuscitation. He refused the treatment for his platelets. He refused the transfusion. You're welcome. So, guys, thank you for today's session. To be honest, I was preparing 4 cases for today, but it seems that you've got lots of questions. So let's keep them for the next session. Be safe, study smart, and never study hard. If anyone still got any questions, please post it in the WhatsApp groups. I would be more than happy to answer it. Thank you and good evening.
Thank you.
Thank you,
Thank you, Dr. Ahmed.